Dr. Claytor here with
Dr. Piccinini.
Down at the MARC, which is the Miami Anatomical Research Center right here in Miami. It's fantastic. We've been dissecting anatomical dissections all day, demonstrating different techniques, refining the anatomical variations for educational purposes, and then we do CT scans to show how specifically how we're moving the highway bone. But brings up some interesting topics of conversation, and probably the one that's the hottest conversation today is what are the differences between a deep plane facelift and really everything else?
Yeah, so that's it's been great to have Brandon here and all our other colleagues. It's been a great few days, and this is an outstanding facility for us to do these dissections and further improve some of our skills and some of the anatomy. We're making an atlas and other very nice activities to teach other surgeons as well these techniques. And it's very interesting because Deep Plane really is trying to, as much as possible, use and reposition some of the patient's anatomy back to where it was originally, versus some of the other techniques such as plication with just stitching, where that gives sort of a little bit more of an artificial look a lot of times, because you're really putting a lot of the tension on your skin, and we feel, and I think that most surgeons nowadays are starting to agree more, that the results are longer lasting with the deep plane.
It's a really interesting discussion, and there are a lot of great, fabulous surgeons, certainly historically, as well as currently, who do not utilize the deep plane technique, and they have their rationale for it, and really their results speak for themselves. So I don't think that either of us would say that one technique is superior to the other, but we have very much our reasons and rationale for why we've migrated and evolved into the deep plane technique. And speaking for myself, I felt that when you lift the skin up off of the SMAS, the superficial muscular aponeurotic system, so that layer between the skin and down into the muscle and the bone, that SMAS layer is very tough, it's very strong, and it can hold a suture really well. The challenge for me was that when you lift up all that skin, you delaminate it. I think it affects some of the sensory components, some of the vascular components, and I find that that skin envelope would relapse quicker than if you left the SMAS attached to the skin and then you went below it. And so in our terminology, we use these terms called composite flaps. And so a composite flap is where you leave two elements together and lift it and move it. And so really the deep plane technique is a composite flap. And I think there are a lot of benefits that come from keeping the SMAS attached to the skin. Two big reasons. Number one, going under the SMAS, you can find those retaining ligaments. And those are what keep that malar mound from mobilizing all the way up. And they're very stout and they're very identifiable. And when you go in there and you find them and you release them, now that SMAS and skin composite flap is very mobile and can lift up. And now you're putting a suture into that very stout SMAS and anchoring it up into the temporal region. So you're carrying the skin along without pulling on the skin.
Yeah, so I think it's fantastic when we look at the anatomy, and when we go to these cadaver labs or in surgery in patients, we really see how powerful these techniques are, where, like Dr. Claytor was saying, where we keep the skin attached in certain areas that we define, and we're able to really mobilize that together. So the vascularity is much better. Probably the swelling recovery might be a little bit better, and just the durability of the results is something that we think, and again,
it's
good
rational
surgeons
based
have different
on
things, but we think that this is a good technique to help with the longevity of the results also.
One of the things that just comes with experience is knowing the difference between a retaining ligament and a nerve. They can kind of look like the same structures. They feel very differently. So your tactile experience is very, very different. And that's where the experience of doing this many times, as well as coming into the cadaver lab and further refining and taking those technical skills to the next level. I feel like we never stop learning. We never stop getting better, and we never stop advancing our ability to identify structures, tissues, through through anatomy, but as we all know, the anatomy is highly variable. So if somebody says, well, this is the anatomy, okay, that can be your guideline to start with, but you better be attentive to anatomical variations. So again, going down underneath that SMAS, lifting up, finding those retaining ligaments. Many times, this was why 20 some years ago when we all went through our training, people weren't really doing deep plane facelift techniques, and it was because there was a reluctance to venture into this area where all these nerves were. Now, I did a fellowship in peripheral nerve surgery, so I'm very, very comfortable working around nerves. It's less of a anxiety event for me, but I certainly know that it's an anxiety event for anybody who hasn't got that kind of expertise. How about down in the neck? What is it in the neck that you think is so pivotal for developing that beautiful jawline?
Yeah, so I think the neck are a few things. One of them obviously is how our mandible and jaw are. The bone is one of the important things, and that's one of the harder areas to shape, but we can shape the contents, right? That's what we do in surgery. So we can take some of the fat out, some of the fat that's deeper under the muscle if we need to. The glands is something that more and more people are recognizing as an important component. Patients sometimes, they'll feel the gland, or sometimes they don't recognize that it's an issue. And we talk to them in the clinic, in the office, that this is something that we need to address to really be able to tuck in the muscle and the skin in order to get better contour. So those are some of the issues. The other thing is the muscle, the platysma as we age tends to fall down, and we get those bands a lot of times. And so when we're doing the deep plane, we're really under that muscle, and we can really resuspend it as a hammock and bring some of these structures back up. So like we're saying, a lot of very good surgeons do plication or deep plane, but I think the neck, we have to go deep in the neck because it's very, very hard if you're not treating some of these deeper structures to get a very good contour.
Yeah, that's an excellent point. We have a lot of patients who come in and say, don't want to do that, and that's fine, Love that you're educated enough to know the difference between these different kinds of surgical techniques, but then it's our opportunity to share with them what might be some of the limitations of not entering into the neck. And sometimes patients say, that's fine, I'm not interested in that. And one of the things that I've really pioneered a lot over the last 5-6 years is a more minimally invasive neck procedure. I call it the MIMS, minimally invasive mastoid sling. And so this is the mastoid bone back here, and you can grab a sling of fascia, which you can really anchor something on and put a permanent suture underneath there without opening up the neck, just liposuctioning it. So it's not removing the gland, it's not getting the fat that might be underneath the platysma. So, but in select patients, it's perfect because super fast recovery, 1 centimeter incision back behind their ear, and they're like, that's what I want. And so it's meeting people where they are and giving them education. And the good news with all of this internet and Instagram and TikTok information, patients are coming in today so much better educated. They start using terms, they're like, are you gonna release the retaining ligaments? I didn't hear people saying that 3 years ago. Now they're like, they understand the nuances between the different techniques, and it's really great for us to have a patient who comes with a almost PhD level education about what we're doing, so that we can have very, very informed consent conversations about what they're hoping to achieve and what can be achieved with the different technique they're looking to pursue.
Yeah, and I think that's a great point. I think being able to offer treatments from A to Z, different options for patients who are worried about a certain part of their face or their neck, or they're concerned about certain procedure, and being able to offer less invasive to more invasive, more thorough to less thorough, faster recovery, etc. Those are all issues that nowadays, having all of those in our toolbox is very, very helpful.
I love it. Well, it's always a pleasure doing Doc Talk with this genius. Thanks so much. Take care.
Thank you.